Good evening, everyone. Sir, with your permission, may I start?
Yeah, go ahead.
So today I'm presenting the case of a 36-year-old lady who hails from Bangalore and is an IT professional by occupation. She's completed her post-graduation. She presented with chief complaints of multiple irregular and tortuous veins in the right foot since 10 years, occasional pain in her right leg since 7 years, and bleeding from her right foot 2 years ago. Patient was apparently all right 10 years ago when she noticed multiple irregular and dilated veins in her right foot during her second pregnancy. They were insidious in onset, initially a few in number, and then gradually progressed over the years, increasing in size and have become tortuous, now involving her ankle and medial aspect of her leg below the knee. She noticed that the veins increased in size on prolonged hours of standing, and by the end of the day, they reduced in size with rest and on leg elevation. She also complains of occasional episodes of pain in her right leg since 7 years, and the pain was described as dull aching, dragging type of pain in her right leg with swelling in her foot while coming home from work, which was relieved on leg elevation and rest and aggravated with long hours of standing at work. 2 years ago, there occurred one episode of bleeding from her right foot. Prior to the bleeding, she'd gone for cycling. Upon return, she noticed a small bleed in her foot, which she ignored as a cut on her skin. Later, she noticed the pool of blood on the floor with profuse bleeding originating in her foot. She applied pressure on the site of the bleed and elevated her leg, which reduced the bleed and, however, did not stop it. So she was rushed to the ER where it was controlled. She underwent tests and scan and then was advised to use stockings and given medications for the same. There was no history of fever with pain and swelling of the leg, trauma or immobilization, consumption of oral contraceptive pills or anticoagulants, pain, abdomen, distension of the abdomen or chronic constipation, discoloration, itching, thickening or ulceration of the skin, and complaints on the other leg. In the past, there was no history of similar complaints. She does not have any history of diabetes, hypertension, or other medical comorbidities, no history of consumption of oral contraceptive pills or anticoagulants, and no history of hospitalization, surgeries, or immobilization of the limbs. Treatment history. She has been using compression stockings and has been taking tablet Daphlon 500 milligrams. Her personal history was as follows. She's a non-vegetarian with normal appetite and sleep. Her bowel and bladder movements are unaltered, and she does not smoke or consume alcohol. She attained menarche at 14 years of age. She has regular cycles of 28 to 30 days, 4 to 5 days of flow, uses 2 to 3 pads per day, which is not associated with dysmenorrhea or passage of clots, and she has no history of consumption of OCPs. There was history of varicose veins in her grandmother, mother, and maternal aunt. So summary, she's a 36-year-old lady, IT professional by occupation who presented with complaints of multiple irregular, dilated, and tortuous veins in her right foot since 10 years, which is insidious in onset and gradually progressive, associated with occasional episodes of dull aching pain in her leg, swelling in the foot by the end of the day, which relieves on leg elevation and rest, and an episode of bleeding from the foot 2 years ago, following which she's been using compression stockings. There is family history of similar complaints. The history suggests that this is probably a case of varicose vein, with family history and onset during pregnancy contributing to the etiology, and hemorrhage is a complication of the same.
Okay, concise presentation. You kept mentioning something about IT professional. Does it have any bearing?
So there would be prolonged hours of sitting, and another thing was the patient travels a lot in the bus, like standing. I mean, she used to do that earlier before the lockdown. That could have a bearing on as an etiology, or it is a risk factor for developing varicose.
Okay, so the standard teaching is that services which involve prolonged standing, like nurses or policemen or teachers, they have a tendency to develop varicose veins. Is it true?
So it's true because when the person is standing for a long span of time, then there's pooling of venous blood in the foot. And that for several years together could result in chronic venous hypertension.
Okay. A small correction over here. See, this is colloquial teaching which we've been listening to for past almost from 4 or 5 decades. Prolonged standing professions do not cause varicose veins. Okay, if they have venous insufficiency, it gets accelerated or it gets exaggerated or it has a earlier onset of complications. But the prolonged standing by itself does not cause venous disease or varicose veins. Can it cause venous hypertension? Yes, to some extent. But another strange thing I noticed that, you mentioned that, the bleeding was from the foot, not from the leg.
Yes, she showed the site of her bleed, and she was like, it was from the foot.
It was from the foot, yeah. Because when we are planning our treatment, this becomes very, very important because usually venous hypertension rarely gets transmitted onto the foot. Okay, most of the bleeding tends to happen somewhere around the ankle or in the leg or when there are dermal blowouts, but there are certain conditions where it reflects in the foot also. So we can go into that too. Why did you mention a history of trauma?
So because if it was a major trauma and it required immobilization of the limbs, then that would have contributed to deep vein thrombosis. And secondary to DVT, she could have had varicose.
Excellent. Another condition where trauma can cause this, if there's a penetrating trauma, you can have a arteriovenous fistula happening. Could be a small one. That also contributes to venous hypertension per se as such. Okay, I think
Yes.
more or less you've covered. Did she say that, she started noticing dilatation of the veins after pregnancy, or she didn't notice that?
So she told about during her second pregnancy, she started noticing it. And following that, like over 10 years, it's like she's been telling that she's developed, like she's seen it become snake-like and tortuous. And she had the other complaints.
And anything to do with the pain? You asked her about pain, and then she gives history of episodic pains happening in the right leg. Where exactly does the pain happen?
So more towards her foot, I mean her ankle and calf was where she told.
Yes. You need to remember most of the venous insufficiency pain happens in the calf region. That is because of calf vein congestion. Okay, and usually tends to happen after 2 p.m. If you're a regular 8 to 5 worker, then at around 2 o'clock or beyond 2 o'clock, that is when the peak of conditions start taking place. And towards the end of the day, you start getting a dragging kind of pain, occasional cramps per se as such. And did you ask her relation of pain with her periods? Did she notice extra pain during her periods?
No, sir, I didn't ask that history.
So when you're dealing with venous diseases, you need to ask whether there is worsening of the symptoms just before her periods, because hormonal imbalances are one of the major components of venous hypertension.
Yes, sir.
And symptoms. Any history of cramps or night cramps?
No, sir, she did not have history of night cramps.
Okay. Okay. Okay, go on. Anything to do with oral contraceptive pills?
Sir, oral contraceptive pills again add as a risk factor towards deep vein thrombosis.
Deep vein thrombosis. Okay, got it. Okay, we'll come to Daflon at a later stage. Go on. I think the most important part of venous hypertension is always the discussion regarding investigations and treatment. Okay.
So shall I continue, sir?
Please.
So general physical examination, informed consent was taken from the patient prior to the examination, and it was conducted in a well-lit room. Her height was 173 centimeters and weight was 74 kgs, with a BMI of 24.72 kg per meter square. Her vitals were as follows. Her temperature was 98.4 degree Fahrenheit. The pulse was 76 beats per minute, regular in rhythm, normal in character and volume, with no radial or radiofemoral delay, and all the peripheral pulses were felt. Her blood pressure was 134/86 millimeters of mercury, which was measured in sitting position in her right arm, and the respiratory rate was 14 cycles per minute. There was no pallor, icterus, cyanosis, generalized lymphadenopathy, or pedal edema, which was noted. Local examination. Patient was examined in standing position with both the limbs exposed on the umbilicus below. An examination was done in standing position, and following which it was done with the patient supine with her leg elevated. On inspection, the left leg appeared normal. The right lower limb, the attitude of the limb is normal with no deformity. There was localized multiple telangiectasias and reticular veins seen on the dorsum of the foot, and tortuous veins seen in the anterior aspect of the ankle in front of the medial malleolus, and along the medial aspect of the leg below the knee, there was some bulging which was noted. Spots of pigmentation of skin are seen on the dorsum of the foot. The varicosity was reducible on lying in supine position and elevating the limb, and the skin texture appears to be normal, which is not stretched or shiny. No eczema, no ulcers were seen. The toenails appear normal, and there's no ulcer or scratch marks on the skin. On palpation, the left leg was normal. The right lower limb, there was no local rise in temperature, no tenderness, no thickening of the skin, no pitting edema was seen. Brody-Trendelenburg's test, 1 was negative and 2 was positive.
Can you just elaborate on that?
So in Brody-Trendelenburg's test, first we make the patient lie down and elevate their limb to empty the vein, following which we tie a tourniquet along the saphenofemoral junction. Then we tell the patient to stand and we remove the tourniquet, and we look for rapid filling of the limbs, like rapid filling of the vein from above to below. If that turns out to be positive, then it indicates that there is incompetency at the saphenofemoral junction.
You really think it's possible to tie a tourniquet at the saphenofemoral junction? Did you have to tie a tourniquet? I don't tell my students to put a tourniquet. No? They can use a finger to stop the reflux and then check whether the reflux happens from above to down.
So we can tie it, like we just make sure that the knot is put laterally. Okay,
fair enough, fair enough. So you can use your finger also to occlude that area and then do the test. But if books say that, put a tourniquet, fine. Because need to remember, if it's a fat individual, this test becomes very difficult to elicit with a tourniquet.
Yes.
Okay. What's the principle of your multiple tourniquet test?
So multiple tourniquet test is to find out which perforator is involved. If at all there is a perforator incompetency, and at what level the perforator is involved in causing the varicosity. So what we do is that we tie like 3 to 4 tourniquets, like from above to below, like one at the level of the saphenofemoral junction, one at the level of the perforator of the thigh, one above the knee and one below the knee. And then we make the patient to stand. So wherever we see that there are blowouts or we notice that bulging, then it's probably because that perforator is involved. Like if it's below a particular tourniquet, then the perforator below that is involved.
So what do you see and how long does it take for the veins to become a little prominent?
So around 30 to 60 seconds.
Okay, wait for a period of 2 minutes. That is when, after making the patient stand up, that is when you can clearly make out the prominence of the veins per se as such. Okay, go on. Fagan's test.
The below knee perforator was palpable along the medial aspect, and modified Perthes test was negative. All the peripheral pulses were felt, and percussion and auscultation did not have any contributory findings.
Fagan's test, what do you really look at?
So we look for the, so first we make the patient to stand and we look for the bulgings which are seen. We mark that and then we tell the patient to lie down supine, and we palpate at the site of those bulgings which were noted to feel for like the semilunar depressions. They are the site of the perforator incompetency. So the deep fascia would have been weakened over there.
It will be stretched out over there. So you get a buttonhole kind of deformity happening again in these kind of patients who are very thin, who do not have much of fat, and for whom there is not much of lipodermatosclerosis. You can elicit these things.
Yes, sir.
Okay, so what is Perthes test?
So modified Perthes is for DVT. So we tie a tourniquet and then we tell the patient to walk. And if they complain of like bursting pain, and if we notice that the veins are getting prominent, then it suggests of DVT.
Okay, it suggests of deep venous occlusion. So why do they get the pain then?
So the pain happens because we have tied the tourniquet, which means that the superficial venous blood does not get drained to the staphanofemoral junction. So it has to go through the deep veins and then through the perforator into the deep veins. Now, if the deep vein has an occlusion, then it does not allow the venous drainage to happen like upwards. So that in turn could result in the pain.
Okay, got you. Again, you seem to be answering all the questions pretty good. How much percentage of the lower limb veins get drained through the great saphenous vein?
So around 10%.
Yeah, that's also. GSV does not contribute much to the venous return from the lower limb. Okay, but it contributes almost around 50% of the vascular surgeon's income. So something is grossly wrong there. Don't you think so?
Yes, sir.
Yes, sir. Yeah, I like that smile of you. That's why I told you at the beginning that, there is a lot more of the physiology of venous system we need to understand. We still don't know that much of it. Okay. Any other questions from any of the rest of the audience? Any postgraduate student out over there? I want you to drill Priya Menon.
There's nothing on the chat box yet.
Okay. Okay. I think they're all happy with your presentation. Okay. Go on. Go back to the previous slide. You said something about percussion and auscultation. So what do you look for in percussion?
So in percussion, we can look for the Schwartz test, that is the thrill. So along the great saphenous vein, it's like if we find one part of the vein which is straight, like a straight column of blood, then we tap on one end and then we look for the thrill felt along the other end.
It basically means that there is a continuous channel of blood with valves not really impeding the flow of blood from above down or from below above. And on auscultation, would you ever find anything abnormal?
So one is that if there's an arteriovenous fistula, then we can look for a continuous machinery murmur.
It's called a what?
Sorry, sir, I didn't hear.
What is the continuous machinery murmur called? If there is a AV fistula?
So I'm not sure what it's called.
It's called as a bruit. P-R-U-I-T. Bruit.
Yes.
Okay, and if you can feel it, it's called as a thrill. And if you can hear it with the stethoscope, it's called as a bruit. So those are sometimes because of hyperdynamic circulation per se, as such gross varicose veins, you do get to see some of them. You get a venous hum. That means there is a continuous flow of blood. You get a venous hum. Well, I haven't heard it. It's been ages since I put a stethoscope on a varicose vein per se as such. But sometimes we do. If we get a doubt regarding a weak thrill, then we put a stethoscope and then we find out that, there is a bruit heard. Next, go on.
On systemic examination, per abdomen was soft, non-tender with no palpable mass. Cardiovascular system S1 and S2 were heard with no murmurs. A respiratory system, there was bilateral air entry with no added sounds, and CNS revealed no focal neurological deficits.
Suppose there was a mass in the abdomen. So what would you tell?
So if there was a mass in the abdomen, then probably because of the mass compressing on one of the veins, it could have resulted in varicosity.
Venous hypertension. Okay. Now, in your inspection, you did not tell anything about presence of any superficial veins in the groin or presence of visible veins in the anterior abdominal wall.
Yes, sir.
You're supposed to look over there also. Okay?
Yes, sir.
Okay. Go on.
So provisional diagnosis. Has
Mhm.
varicose veins of the right lower limb involving the great saphenous vein with incompetency of the below knee perforator without clinical evidence of deep vein thrombosis. As per the CEAP classification, it would be C4A, EP, ASP, and PR. That would be in like clinical 4A because there was some pigmentation which was noted along the dorsum of the foot. Etiology is primary because there was no DVT. Anatomically, it is involving both the superficial venous system as well as the perforator, and pathophysiology most likely is a reflux.
Okay. Okay. Now, let's go a little more into your diagnosis per se as such. So if you really break it down, do you think there is a saphenofemoral incompetence or there is no saphenofemoral incompetence?
So there was no saphenofemoral incompetence.
Okay. And most of the uh, veins were in the great saphenous vein territory or the short saphenous vein territory?
Great saphenous veins.
Okay, great saphenous vein territory. You said something about telangiectasia and reticular veins in the foot.
Yes, sir.
Yes, can you elaborate on that?
So telangiectasia would be when there are these small intradermal veins which are less than zero point 0.5 to 1 millimeters in size. They're
Mhm,
described as spider nevi.
mhm,
And reticular veins would be when they are between like 1 to 3 mm in size,
mhm.
which are also dermal veins.
Okay, so you need to remember uh, the location of these veins. Like you said, it's essentially intradermal. So treatment also is a bit tricky with respect to these veins per se as such. And the more spider veins you see, it goes more in favor of a hormonal component or veins happening during pregnancy, uh, which shows up as spider nevi or spider veins. I wouldn't call it as spider nevi. I would call it as spider veins. Okay, and okay, also notice that there is slightly excessive pigmentation in the lower leg around the ankle. Why do you think this pigmentation has happened, Priya?
Um, Sir, am I audible?
Yeah, yeah.
Just got stuck. Yes, sir. Um,
Did you
so,
hear?
yes, sir. Your question was on pigmentation.
Pigmentation, yes.
So pigmentation happens because once there's like chronic venous hypertension and stasis of blood, it would affect the microcirculation and the RBCs. They move out to the tissue plane, and on undergoing hemolysis, they would produce hemosiderin, which results in the pigmentation.
Excellent. Okay. You said something about venous hypertension.
Yes, sir.
Yeah. So what is a normal pressure inside a vein?
It's around 5 millimeters of mercury.
That's quite a lot. At the ankle level, when the patient is lying down and when the patient is standing up.
Um, so I'm not sure.
I'm not sure as such. No? It varies between when the patient is lying down, it's somewhere between 0 to 3, and when the patient is standing up, varies between 3 to 5.
Yes, sir.
Hardly crosses beyond 5. So we will come to what is venous hypertension and where are the spots where venous hypertension tends to happen. Go on, next.
So investigations.
Let's stick to the relevant ones. Let's take all the other tests as normal. You're talking about duplex imaging of the venous system of lower limb. Yes, go on.
So then I mentioned the slide on treatment.
No, okay. Now tell me something about the duplex scanning. What is the report of this patient?
So can I share my screen regarding the report? There was a lot in the report. Just a second, sir. So is my screen visible?
No. It says has started screen sharing. You can read out the report, Priya. We will abide by whatever you say.
Yes, sir. So the report says that in the right limb, the common femoral vein showed no reflux. The saphenofemoral junction showed no reflux. There was severe reflux seen in the great saphenous vein above the knee and below the knee. And the superficial femoral vein proximal, the middle and the distal segment had no reflux. The popliteal vein had moderate to severe reflux, and the posterior tibial vein also had reflux, which is moderate.
So what do you interpret from this?
So that the perforators above and below the knee were involved.
Okay, so there are two components of couple of components of analyzing this report per se as such. One, it says there is no evidence of deep vein thrombosis. So there is no occlusion as such. Next, there is an element of deep venous reflux. Okay, deep venous reflux happening in the popliteal vein as well as in the posteriotibial veins. Am I right?
Yes, sir.
Okay, and then when it comes to perforator incompetence, the mid-thigh perforator have the said anything about that?
Yes, sir. They have mentioned that there is an enlarged incompetent Hunter's perforator on the right side.
That's pretty good.
62 centimeters from medial malleolar process.
Okay. So this is one of those few cases where you have saphenofemoral junction, which is competent, but you have a mid-thigh perforator, which is incompetent, and couple of perforators below the knee, which have turned incompetent, leading to venous hypertension per se as such. Okay.
Yes,
now, before coming to the treatment part per se as such, like I keep telling you, it's very important for us to understand why this episode of bleeding happened and why is there incidence of bleeding from the foot as well as dilated veins in the foot. Okay, a typical varicose vein per se as such as a result of a saphenofemoral junction incompetence or a saphenopopliteal junction incompetence and perforator incompetence below the knee usually does not cause too much of problems in the foot. They all tend to settle down towards the ankle and rarely you get grossly tortuous and dilated veins happening in the foot. So if you look at your Doppler report or your duplex scanning report, it's pretty good. He's given us an area to start thinking about. That is presence of severe reflux in the popliteal vein and the posteriotibial vein.
Yes, sir.
Okay. Now, for us, when we are planning a treatment for this patient, it's very important that, just taking care of the superficial veins alone per se as such is not going to get rid of the venous hypertension as such. So it is mandatory for us to help in reducing the venous hypertension because of deep venous reflux as such. Any General surgery PGs out there in the audience?
So they can unmute themselves if they are there.
Okay, I think you're the one who's stuck, Priya. You have to take my questions and answer
Yes,
it.
sir, no problem.
Okay. Okay. So with no, let's proceed further and see how do we treat this patient. How would you proceed further? Now we know what the diagnosis is, and rest of all the other parameters are pretty good. Yeah, I think Sushmita Mali is okay. No, she went off. I thought she wanted to say something. Okay, go ahead. How would you like to treat this patient?
So currently the patient is on compression stockings and taking diosmin, with which she's telling that her complaints of pain and edema have come down. But since the deep veins are also involved, later on it could cause a problem to the patient. So surgery can be done, sir, but I'm still not sure how. This is the small segment of the vein which is involved. Clinically.
So what you need to slowly start thinking about is, don't mention the word surgery per se as such. Some form of intervention needs to be done. Okay, this intervention could be in form of surgery, or it could be in form of a minimally invasive procedure or a less invasive procedure like a laser or a radiofrequency ablation, or it could be in form of sclerotherapy.
Yes, sir.
Okay. The bottom line for treatment of this patient with venous hypertension, I would agree with whatever the first doctor has done, that is stop the bleeding and put the patient on stockings. Okay. And he also happens to put the patient on Daflon or a phlebotonic. We use the word Daflon, calcium dorbicillate, diosmin, venusmin. All these things are belong to a category known as phlebotonics. These phlebotonics will reduce the venous hypertension to some extent. All these things act on the capillary level. It does not act on the grossly tortuous vein per se as such. Acts on the capillary level, reduces the venous hypertension induced edema, which happens in these patients. Yes. And yeah, it has been known to help in venous ulcer healing, if at all it happens, and reduce the incidence of further bleeding. But a phlebotonic by itself as isolated therapy does not work unless it's combined with stockings.
Yes.
Okay, so when you mention the word stockings, if you are a postgraduate, I've asked you to describe the stockings per se as such, but let me treat you as a postgraduate itself. And can you describe the stockings to me?
So there are like several types of stockings. The one this patient is using is basically a compressive type. It's like an elastic one she's wearing.
All stockings are elastic, Priya. Even the cosmetic ones you wear to a party are also elastic. You are finally a doctor. You can't use things like that. You have to be very, very specific.
I don't know how to describe the stocking per se. I know how they act.
How they are. Okay. At least let's start off saying that, the stockings were up to the level of the knee or it extended into the thigh.
So she wore it up to the level of the knee.
Okay. It's called as below knee compression stocking.
Yes, sir.
Okay. So next one is anatomical location of the stocking. How long does it come up to? Next step is we need to try and find out what is the level of compression. So did you ask her, was it class 1, class 2 or class 3?
No, sir, I didn't ask her that.
You didn't ask her that. So when you are given, so when you finish your internship and when you're practicing and somebody comes with a similar kind of bleeding to you, so then you are supposed, if it's for venous hypertension with not much of lipodermatosclerosis and not much of skin changes, ask for class 2 compression stocking.
Yes, sir.
Okay, when we say class 2, there are three different types of stocking. One is class 1, class 2, class 3, class 4 also. Class 1, essentially, again, it depends on whether it's the American system of measuring it or the European system of measuring it. Class 1 is for mild.
Based on the pressure, sir,
Yes.
that the stockings apply.
Yes. Based on the pressure itself. Okay. So, but when we talk about class 1, it's usually less than 10 millimeters mercury pressure or 12. Again, depending on the American system or the European system. Class 2 varies between 14 to 20 or 10 to 20 millimeters mercury pressure. Sometimes it goes up to 22 millimeter mercury pressure. Class 3, again, take it around 25 to 32 or 35. Class 4 at around 40 millimeters mercury pressure.
Yes, sir.
So how do you decide on this? So, yeah, go ahead, please, Priya.
It would depend on the underlying cause to know how much pressure to apply. Like, for example, if it's just mild varicose veins or edema, we would give the type 1 stockings, so the grade 1 stockings. If it is because of DVT, then would give a higher pressure compression. So grade 3 there, and remember grade 2 and grade 4.
Yeah, grade 2 is what you need. For varicose veins or venous insufficiency, what is recommended is class 2 compression stocking.
Yes.
Whereas for deep vein thrombosis, it's class 3 compression stocking, and chronic lymphedema goes to class 4 compression stocking. So this patient has come to you, and in spite of wearing stockings, she's developed further bleeding. So what will you ask her when she comes to your clinic?
So the bleeding was before she wore the stockings.
Yeah. Now, let's start putting hypothetical situations now. No, you're laughing. I need you to be tense when towards the end of the program or presentation. So that means I've not questioned you adequately. Second time she's come back to you saying that, doctor, I'm wearing the stockings that you've given, and I had one more episode of bleeding. So what would your questions be like?
So what was the site of the bleeding? This time, was it as bad as the previous bleed? And again, like, I would think in terms of progression of the varicose itself and it being more severe. And again, I would like to know if the patient is having any bleeding tendency or bleeding diathesis which has resulted in this, like severe bleeding.
Okay. So what you need to ask, she's doing all the right things, but the first step, what you need to do is, are you wearing your stockings? She says yes. So what time do you wear your stockings? So if she gets up at 6 o'clock, the correct way of wearing your stockings is you need to insert your stockings or insert your leg into the stockings within 45 minutes or 1 hour of getting up. So many of the people, what they end up doing is they get up at 6 o'clock, finish all their household work before going to the office, wear your stockings by 9:30, 10 o'clock in the morning. So what it does is this 2 hours, within 45 minutes or 1 hour, if you wear it, the incidence of venous hypertension is reduced significantly. If you start wearing it after 2 hours or 3 hours, it doesn't serve too much of a purpose in helping the venous return because congestion has already taken place. So it's very important for us to recommend to patients to wear the stockings at the earliest before waiting for too long. So get up, finish your toilet activities, bath, wear your stockings, and then do all your other works.
Yes.
Majority of the bleeding and majority of the symptoms of venous hypertension, that is calf cramps, calf discomfort, edema, starts coming down with appropriate usage of stockings. So way before all the teaching program started, I asked you that, do we think we know much about venous hypertension of varicose vein? This is where I say stocking is the bedrock of treatment of venous hypertension and varicose veins. It is not surgery, or it is not laser, or it is not any other form of therapy. The cornerstone, the first line of treatment usually is venous compression stocking. Because like you mentioned yourself, okay, like if the patient had saphenofemoral junction incompetence, okay, what would your line of treatment be?
So then the intervention would be surgical.
Yeah. So you would recommend some form of surgical correction, uh, like what, Priya?
So one would be the Trendelenburg's procedure, that saphenofemoral flush ligation surgery.
And
But since the complications with that,
no, let's not go into the complication. Let's talk about the surgery per se as such. That is
yes,
why I was looking for a surgery postgraduate students in the audience, but looks like they've all deserted you. You are the person holding the torch. Yeah. Flushed ligation of the saphenofemoral junction. That is called as a Trendelenburg
Trendelenburg
procedure.
surgery operation. Yes, sir.
And then that's
Sorry.
it. Just ligating the saphenofemoral junction is enough.
No, sir. We have to strip the vein after that.
Yes, you strip the vein. From where to where do you strip the vein?
So we'd start from the saphenofemoral junction to above the knee.
Above the knee, just below the knee is what is recommended in surgery per se as such. Okay, just below the knee, not above the knee. And you don't go into the mid leg. You do not go into the mid leg or below, because the risk of injury to the saphenous nerve is always there. So you do the stripping above downwards or below upwards. It's just the surgeon's preference per se as such. So you do the stripping. Then
So following the surgery, we would tell them to use the compression stockings.
now in this patient, okay, in addition to all the other things, you have saphenofemoral incompetence. We have done surgery. Do you think this will take care of her problem per
No,
se?
sir. Because the perforators were also involved and the deep veins are also showing reflux.
Mm-hmm. So you can take care of the perforator incompetence as such. So you can do a small, once you get ultrasound marking done of the incompetent perforators, you make small incisions, do a ligation of the incompetent perforator and the branch varicosities, and then you prevent blood from refluxing from the deep veins into the superficial veins.
Yes, sir.
Okay, the normal flow of blood is from the superficial veins into the deep veins, and then the venous return happens. And here, because of venous perforator incompetence, you have blood coming from the deep veins into the superficial veins. And that causes venous hypertension. Sometimes when the patient is jogging or when the patient is walking briskly or exercising, the pressure in the veins, especially at the ankle level, if there are large incompetent perforators, the pressure in the vein goes up to 110 or 120 millimeters of mercury.
Yes,
So
sir.
that is how bad the venous hypertension is. So that results in rupturing of the capillaries or extravasation of blood from the venules, giving rise to hemosiderin deposition per se as such.
Sir, I had a
Hmm.
doubt with respect to the ankle perforators, since there are so many, and can we on duplex assess the ankle perforators itself?
Yeah, see, in this particular patient, we need to tailor our treatment based on what this patient has. Now, this patient, if you look at, if you really go through the Doppler or if you start doing the Doppler yourself, you will find one deep venous reflux in the popliteal vein and the posterolateral vein. She's going to start developing a lot of perforators around the ankle, inframalleolar, and in the lateral malleolar region also. Normal flow of blood is always from the superficial vein system into the deep venous system. You agree?
Yes, sir.
Okay. Now, the only area where this contradicts itself is in the foot. It's in the foot. In the foot, blood does not drain from the superficial venous system into the deep venous system. It is the blood from the plantar aspect of the foot which drains into the dorsal. So here, normally blood drains from the deep venous system into the superficial venous system.
Yes,
And then, so this is an area where there is venous hypertension happening. because blood drains from the deep veins from the foot into the dorsum of the foot. That is the dorsal venous arch. So, and then it goes into the great saphenous vein or the short saphenous vein, and then it goes back. So we can identify perforators through duplex scanning at the level of the ankle, as well as the lower leg and mid leg. And most of the perforators that we identify comes from what is called as the posterior arch vein of the great saphenous vein. It is not from the great saphenous vein per se as such below the knee. It's mainly in the posterior arch vein. That is why they said there is no need for us to strip the great saphenous vein from the ankle to the saphenofemoral junction. One is to prevent the injury happening at the saphenous nerve. The other one is, even if you do the stripping, if you do not address the perforators going from the posterior arch vein, then the entire operation is futile. So we identify the perforators with duplex and then we fix it. This is according to surgical correction as such. Now, if you show me the photograph of this patient, especially near the lateral malleoli, especially if you can go back to the photograph with her lying down and leg elevated.
Just a second. Kunj, can you share the PPT again?
In examination, you showed me her
yes, sir.
Leg and foot. This one.
Yes.
Now, if you notice, there are two black spots just above the lateral malleoli. Can you see that?
Yes, sir.
Okay, and one dark spot in the foot, in the midfoot,
Yes,
more on the lateral aspect. These are what is called as dermal blowouts. Okay, these are the areas which tend to bleed again. The gross varicose veins usually do not bleed. It is these dermal blowouts which have a tendency to bleed as such. This cannot be treated with surgery as such. So here we do what is called as injection sclerotherapy. Sclerotherapy. So coming to the principles of treatment of varicose veins. Okay, so here you're dealing with three different components as such. One is saphenofemoral junction incompetence. Second one is the varicose vein, that is the dilated vein. Third component is the perforator incompetence, giving rise to varicosities in the leg. We cannot and we are not addressing the deep venous reflux as such, because deep venous reflux can be addressed only with respect to by stockings, unless it's gross and we decide to do a deep venous reconstruction. So one option you have was surgical option is what you mentioned as such. So what are the other options according to your Love and Bailey textbook?
The other options are, barring the Trendelenburg surgery, there are minimally invasive techniques as well. One of them is the subfacial endoscopic perforator ligation.
Okay, all this is surgery. We've gone beyond that now.
Injection sclerotherapy.
Injection sclerotherapy. Okay, then. You've heard of laser ablation of varicose?
Yes, laser ablation. Then the Trivex method.
Trivex method. Okay, see, you're going, your thought process is going a little haywire. Okay. You mentioned about radiofrequency ablation. Somebody mentioned about radiofrequency ablation and endovenous laser ablation. These are methods. These are methods by which the varicosities in the great saphenous vein as well as the great saphenous vein territory are addressed by a minimally invasive technique. So there are various components of it. So you use an energy source which gets delivered either as laser or as radiofrequency ablation, and you damage the vein, the endothelium of the vein, resulting in thrombosis of the veins as well as fibrosis of the vein and occlusion of the vein. So instead of stripping this segment from the knee till the saphenofemoral junction, you ablate the vein under ultrasound guidance. And there was one more gentleman who said you can use cyanoacrylate glue. So this segment of the vein, the great stiffness vein between the knee joint and the groin, ablation happens with a lot of newer techniques. The earliest to start was the laser ablation. Then came the radio frequency. Then you have cyanoacrylate glue, where you inject glue into the vein, which causes obliteration of the vein. You come out. And then you have steam bubbles coming into the picture. And then you have specialized devices which give you injection foam sclerotherapy giving into the great stiffness vein. So you are addressing the great stiffness vein in the reflexive segment of the thigh by using these methods per se as such. Are they equal to surgery? More or less radiofrequency ablation and endovenous laser ablation is equal to, more or less equal to surgery in taking care of the veins in the varicose veins in the thigh segment up to the knee. Now it comes to below the knee perforators per se as such. Laser radio frequency ablation is quite helpful under ultrasound guidance. We can take a different probe, go directly into the perforator, which can be done with laser also under ultrasound guidance, and you can ablate the reflux happening. Incompetent perforators can be taken care. The third component is, okay, you've done saphenofemoral junction, you've done the GSV, you've taken care of the incompetent perforators also, but you have those bunches of veins still there. Okay, those bunches of veins can either be taken care surgically, where you do a small stab phlebectomy and you extract the vein out, or you can treat it with injection sclerotherapy, where you can use various agents. What are the agents you know of, Priya?
So this sodium tetradecyl sulfate, sodium morylate, ethanolamyl oleate, and polidocanol.
Okay, excellent. So most commonly used are cetrol or sodium tetradecyl sulfate, or sometimes you can do polidocanol. Polidocanol is very, very useful when you're treating these kind of small reticular veins and telangiectatic veins, because it has a component of local anesthesia also in it. So the stinging pain which is felt by the patient when you do a sclerotherapy is reduced when you use polidocanol. Okay. Okay. Once you've taken care of all these things, then what do you tell the patient? I've done my surgery. I've collected my money. I paid my installment for this year, this month's car installment I've done. So what do I advise the patient?
Sir, I'm not able to hear you. My internet connection seems unstable.
Okay, can you hear me now?
Yes, sir.
Okay. What is the advice to the patient after you finish your procedure? You've done your surgery, you've done your sclerotherapy, you've taken care of the patient pretty well. All these bunches of veins are gone. So what do you tell the patient in the post-operative period?
So post-operative period, it would be best to keep her legs elevated.
That is very, very unscientific. Your human body is not designed to keep your leg elevated. Okay. Again, it's constantly told that, keep your leg above. No, you cannot keep your leg above, because, as long as you're standing and walking around, it's not possible. So
the compression
stocking. Please, you need to tell her that you're young. This venous hypertension and varicose veins and your spider veins will increase with age. You need to come back at regular intervals for follow-up. This is not the end of it. So do not, before subjecting her to surgery, you need to explain that the risk of recurrence in her is going to be pretty high, because she's got deep venous reflux also. So compression stocking has to be worn throughout, and she's not grossly obese, so she has to wear compression stocking long term to prevent recurrence of these kind of diseases. After 5 years, if she comes back to you with dilated veins like you see in the second photograph, what do you do? Priya,
So
can you?
is it, um, so is it because the reflux and the deep veins are so severe that it would be causing that?
Yes, the deep venous reflux, and here it is the posterior arch vein which is incompetent, giving rise to these kind of things. She will come back at recurrent intervals with these kind of veins. So you need to tell her in the post-operative period, she's going to need repeated episodes of injection sclerotherapy. Need not be subjected to surgery. She needs repeated such episodes of injection sclerotherapy. This sclerosant injection can be done directly, or that means you cannulate the vein and then inject the sclerosing agent and compress the vein. Or there is another modified technique called as foam sclerotherapy, where a larger surface area of the vein can be taken care by mixing the
Agent with
sclerosing
air.
agent, yeah, with air, and you develop a detergent kind of action with bubbles. So you cannulate the vein and you inject it inside over there. Yeah, like Himanshu says, that's called as the Tessari's method, by which you create the detergent or the bubbles. So please assure her and reassure her that she has to wear her stockings throughout. Otherwise, this is going to come back to her at multiple sites over and over again.
Yes, sir.
And most probably, like I agree with your diagnosis saying that this is a primary cause because it's developed pretty early in her life. And she's got her parents and her grandparents, which had the similar kind of problem. So deep venous reflux also is pretty common in primary varicose veins. So just doing surgery is not the answer for these patients per se.
Yes, sir.
Any other questions? I would appreciate some questions from the audience. Could you please elaborate on the CAP classification? Okay. See, when it came to description of varicose veins per se, everybody started having different interpretations of varicose veins, and there was no standard reporting practice happening all across the world. So that is why you used to get different kind of reports from different places. So they decided to make what is called as the CAP classification, where I think the clinical signs and symptoms 0, 1, 2, 3, 4, then the etiology and the anatomical and the pathological classification which happens. So this will help us in reporting. So whether a patient is seen, and if you do the CAP classification and enter it in Ramaya Medical College, and even if he goes to PGI Chandigarh, and if you mention the CAP classification, you will have a standard form of treatment or the standard form of analyzing what was there with the patient. So CAP classification helps us. All you need to do is follow it 2 or 3 times, then automatically it comes to your practice and you will enter it immediately. I just happened to see a question regarding the role of steroids. Can somebody open up the?
So the question was like, can steroids cream can be given for dermal flares or other manifestation of varicose veins?
Yeah, steroid cream can be given for patients who've got venous eczema or severe lipodermatosclerosis. It helps for dermal flares per se as such. If it is associated with severe itching, it helps. Otherwise, it does not help per se, as it does not help in treatment of dermal flares. But any eczematous changes, itching and lipodermatosclerosis, it definitely helps in taking care of it. And There's another question in duplex. How do we assess deep venous reflux per se as such? So again, subjecting the patient to a Doppler ultrasound or a duplex scanning, one in the supine position and one in the standing position, you can quantify the amount of reflux taking place, and you'll see dilatation of the veins, as well as you can see the valvular dysfunction now. Nowadays, Doppler machines are, duplex scanning machines are extremely sensitive, and it gives you precise anatomic location of the incompetence, and the extent of incompetence also is clearly seen when you do a duplex scanning, and usually anything about 2 seconds is reflex time is considered pathological.
Thank you, sir.
What is
I
the
had this doubt, sir,
Mhm.
that like are all the signs, can we elicit which like all the perforators which are involved on examination?
In advanced stages, yes. You can see basically what these things are done. All the tests were done in the mid previous century when you didn't have all the other modes of examination. It used to tell us where is the approximate location of different kind of perforators. Okay, so yes, it does, not to the precise extent. Yeah, like you said, it tells you, peri just above the ankle, you have one set of perforators, 5 centimeters, 10 centimeters, 15 centimeters below the knee, and the mid thigh perforators are told. There are many perforators which are there. We need to find out which are the diseased ones. They give us essentially the perforators which come out from the posterior arch vein. Sometimes you get incomplete perforators coming from the anterior communicating vein, which goes into the anterior tibial vein. Some abnormalities, you get varicosities. You need to remember, varicose veins do not read textbooks. It need not always happen in the GSV territory alone. You will have isolated varicosities happening in the mid-leg anterior aspect. It doesn't come to the GSV. All your GSV veins and your GSV territory is completely normal. Sometimes in the posterior aspect, you have the vein of Giacometti, which goes coursing across in the popliteal fossa and going across into the mid-thigh. And rest of all the veins are normal. So it's very important for us to know the physiology and then plan for treatment. So if the patient has saphenofemoral junction reflux and he also has venous, the vein of Giacometti going, treating the saphenofemoral junction reflux with surgery or with laser is not going to take care of the dilated vein in the posterior aspect. So treatment has to be individualized per se as such. And most common complication of venous insufficiency or varicose vein is actually cosmetic. Okay, and the most common indication asked by the patients to undergo some form of intervention is actually cosmetic. We usually as surgeons, we tend to say, okay, if there's secondary changes, lipodermatosclerosis, severe pain, repeated episodes of bleeding or ulceration, only then come in for surgery. But most of the youngsters, if they see a dilated vein, they say that needs to go out. They do not want to be seen with bunches of dilated veins, whether it is men or women. Cosmesis is one of the most common complaint given by the patient per se as such. And secondary pigmentary changes tend to happen, again, which is extremely disturbing because it happens in the gaiter area, which is easily visible just above the ankle till the mid leg. And once excessive pigmentation sets in, even if you do a surgery or if you do a correction and you send them to the best of the dermatologists, that pigmentary changes will not go away. So earlier stages of pigmentary changes, aggressive treatment in whatever form is appropriate for the patient needs to be done. And we also know about other complications like one is extra pigmentation, prolonged hemosiderin deposition resulting in lipodermatosclerosis and inverted champagne bottle kind of leg. The later complications, most important complications, they start going in for phleboarthrosis of the ankle joint. That is, terminal stages So there is intense fibrosis happening in the ankle joint, and ankle joint movement is severely compromised. And in the post-operative period, as well as if the patient asks you what kind of exercises can I do, standing tiptoe and active ankle movements are most important in treating venous insufficiency. Just wearing stocking is not the answer. So ankle movements have to be there.
Yes, sir. So there's one more doubt. There's how do you prevent injury to the skin while doing endovenous high energy sources?
Injury to the skin is prevented by what is called as tumescence. So what we do is once we cannulate the great saphenous vein, and then we put a laser fiber going just proximal to the saphenofemoral junction, then we are going to start firing the laser to obliterate. Now, before firing the laser, under ultrasound guidance, we're going to put a needle inside and then infiltrate with normal saline so that it acts like a cushion. And some people, they use tumescent anesthesia also. Many of the centers do it under local anesthesia. So you have needle which goes inside, and then you inject it perivenous so that there is a water cushion round the great saphenous vein, and the energy transmission to the skin does not happen.
Yes, sir, understood. So one more doubt. They are asking about the management of venous ulcer if it develops.
Yeah, once a venous ulcer develops, then it is mismanagement on our side, which has happened on a very, very large scale. That is one of the terminal event of venous disease, formation of a venous ulcer as such. It's a very, very complex thing. So one, we need to start seriously getting rid of all the refluxes which are happening. You need to remember there is long-standing lipodermatosclerosis in this patient before they go in for venous ulcer, or in the earlier stages itself. Sometimes there is slightly excessive pigmentation which takes place, and then there is a small injury or they start scratching, resulting in formation of an ulcer. So once ulcer forms, that means the skin is extremely devitalized in the gaiter area. One, get rid of all the refluxes taking place, so that you get rid of the saphenofemoral junction incompetence, and then you get rid of the GSV reflux, get rid of the perforator reflux, perforator incompetence, and then if the venous ulcer is very small, you go on to a modification of a Unna boot or a Unna boot regimen, or a 4-layer bandage, or you get what is called as an ulceric stocking, which is a 2-layer stocking, which gives you around 30 millimeters of mercury around the ankle, which helps in healing of the venous ulcer. Okay, 20-year-old having chronic DVT, having IVC filter, insertion in 219, family history also. Okay. I'm surprised. What's the engineering graduate coming in the White Army schedule over here? But doesn't matter. He has a query over there. Can somebody see the chat? A 22-year-old engineering graduate having chronic DVT, having undergone IVC filter insertion in 2019 and radiofrequency ablation for varicose veins in 2020. Whoever this young boy is, who's got pretty severe venous disease per se as such, has got chronic DVT. That means at 22 years, if he's got chronic DVT, that means he's got a thrombophilia or a condition which leads to blood clotting as such. So he needs to be on anticoagulation for a very, very long time. And he's already undergone an IVC filter insertion to prevent a pulmonary embolism from happening. And since he's only 22 and he's got varicose veins and he's already undergone radiofrequency ablation for the varicose veins, so that episode of varicose vein is sort of sorted out. But he needs to continue wearing his stockings and revisit his vascular surgeon at regular intervals, because one, he needs to be on anticoagulation for a long time. Second, he's got a foreign body inside his IVC, which is okay. but it is thrombogenic. And the other thing is varicose veins have a tendency to recur, though in different places. So he needs to keep a regular follow-up with his vascular surgeon as such.
Yes, sir. So those are the doubts as such.
Yeah, he's taking Dabiclot tablet. The Dabiclot is dabigatran. That is one of the newer oral anticoagulants. So that has to be taken for a longer duration of time to prevent further thrombosis from happening. He's been wearing compression stocking for 3 years. I'm sorry to say, young boy, you'll be wearing stockings for a very, very long time. And you need to make sure that your skin is adequately moisturized because you're extremely young. I hate for you to develop and you have chronic DVT. So the incidence of post-phlebitic syndrome is quite high, but can be sorted out. Can you consult me? Of course, you can always come and consult us. But you're on the right kind of treatment. Whoever is treating you right. So just follow with whoever it is.
ನಾವ್ ಹೇಳೋ ಮಾತಿಗೂ ಸ್ವಲ್ಪ ಕೇಳ್ರಿ, ಹ್ಞೂ ಅನ್ರಿ, ಕಿವ್ಯಾಗ ಹಾಕೊಡ್ರಿ, ಕಿಶದಾಗ ಹಾಕೋಬೇಡ್ರಿ ಮಾತ್ನ.
Sorry, so I think someone's audio went on unmute. So you were also on mute.
Am I audible now?
Yes, sir.
Yes.
Okay, I think the host had a small heart attack over there. Somebody's wife was belting the husband.
Yes, sir. Those are the doubts.
Mhm.
Even on YouTube, no more doubts, sir.
Okay, and
Yes, sir. So any concluding remarks regarding the presentation?
presentation is pretty precise. Like I always keep telling that, you guys all do a very good presentation when you have time to write up all your notes. At some stage, I'm going to start asking you to close the laptop and then make a presentation, or close the slideshow and then make a presentation. Because, your presentation involves eye contact, your presentation involves your hand expression. But in this current pandemic, yes, it's difficult. But I'd be very happy if you can make a presentation without reading out whatever is there, whatever you've written down. You have written it down, you have typed it out, you have rehearsed it. And when you read it verbatim, whatever is written over there doesn't inspire confidence. You've done a good job in presentation, but we are not satisfied with you being good. You need to be better, and you need to be the one among the best.
Yes, sir.
Because you're like always keep telling, I want you guys to be so good that you are the people who are going to treat people like us. So when I come out with some form of disease, I want to have a very, very confident doctor treating me.
Yes, sir. Yes, sir. Well, that's all. Yes, sir. Thank you very much, sir. It was indeed a very comprehensive clinical class. The discussion was very useful for us, and we are ever grateful to you. And we seek your blessings, guidance, and support throughout. It was a great great effort by Ms.Priya. We could learn a lot because of your well-prepared presentation. We also thank all the participants who were enthusiastically answering and were actively involved. Thank you, one and all.
Thank you very much, sir.
Thank you, sir.
Thank you. Thank you. Good night, everybody. Stay safe.
Good night, sir.